Hello and welcome to the SHSMD webinar, 5 Key Primary Care Considerations to Drive Access and Lives Capture Health. SHSMD would like to extend a sincere thank you to HSG Advisors for sponsoring today's webinar. Before we begin, I'd like to cover a few housekeeping items. First, please note that the first portion of this webinar is pre-recorded and will be followed by a live Q&A. We welcome your questions and comments, which you can submit by clicking the chat icon in the lower right-hand side of your screen at any time during this presentation. It is now my pleasure to introduce today's speakers. Travis Ansel is Managing Partner at HSG. His focus is on helping healthcare organizations with organizational level strategic planning, physician alignment strategy, employed physician network strategy, and value-based care strategy. Dr. Terry McWilliams is the Director and Chief Clinical Consultant at HSG. Travis and Dr. McWilliams, the floor is yours.
Hey, thank you. And everybody, appreciate the time today. We're here to talk about key primary care considerations to drive access and patient capture. My name is Travis Ansel. I'm Chief Executive Officer of HSG Advisors, a consultancy based out of Louisville, Kentucky, but working nationally with nonprofit hospitals and health systems. I've been in this industry going on the better part of, 20 years now. And do a tremendous amount of work helping health systems do market planning, strategic planning, growth planning, and then primary care, of course, being a real critical consideration in all of those initiatives. And I'll ask Dr. McWilliams, who's here with me, to introduce himself as well.
Thanks, Travis. Terry McWilliams. I'm a family physician by background and training. I've been with HSG just over 9 years now. In my past, I was the chief medical officer at a hospital for about 10 years, which is where I came to know the group. And before that, I was in full scope family medicine practice within the Navy, including OB and procedural areas. With HSG, I provide overall clinical leadership across all of our service lines as a chief clinical officer, and have particular responsibility in the area of employed network transformation. That service line tends to help health systems transform the direction of the network with a focus on aligning vision and building structure, leadership, governance, and other elements that are necessary to support the organization achieving a high performance level. Clearly, the things we'll talk about today meld with all those areas, and it's a pleasure to be here with you this afternoon.
Great, thanks, Terry. So in terms of organization of the presentation today, we wanted to give just some general background observations about what we're seeing related to things that might drive primary care strategy for hospitals and health systems in 2023. Then we want to talk about some specific challenges and considerations for how health systems should approach their primary care strategy. And then today we'll wrap up with questions and discussion submitted as described through the chat function. And we'll tackle those at the end of the presentation. So starting with observations about primary care in 2023, I think three main things came to mind as we started to put content together. So one, I think from our perspective, but also from the industry's perspective, there's an increased competition for patient lives and a real focus on the overall value, as hard as it is to talk about patient lives in terms of their financial, their economic value, but a focus on total value of the patient life, and in particular for our community and regional hospitals. We're seeing a lot of pressure in their maybe historically isolated markets as we see more regional and tertiary systems pushing in, just of course with that mandate for top line growth, and seeing primary care be both a strategy for helping keep those competitive dynamics at bay, as well as kind of being the first entry point that those tertiary or regional competitors might come into a market with. We're also seeing a lot of non-health system aligned entities, virtual health, telehealth, retail, et cetera, that are, it varies heavily market to market. But we're definitely starting to see some penetration of all of those modalities of primary care, starting to disrupt, the historic, bricks and mortar primary care model. So keeping that in mind. The second part is, which would probably be no surprise to any hospital or health system, most markets, as we do, medical staff development planning or community needs assessments across the country, it's very rare to find a medical staff that doesn't have 25 to 30% of their primary care physicians at risk of succession planning, probably in the next 3 to 5 years, if not through the end of the decade. I think there's an industry-wide recognition that advanced practitioners will continue to have to play a larger and larger role in the delivery of primary care. However, we're seeing that market to market, organization to organization, the deployment and utilization of advanced practitioners varies wildly. And so that's something we'll want to talk about today, is kind of best practices for utilization of APPs. And then the third dynamic we're seeing is just what feels like it's, again, my entire time in this industry from the mid 2000s, feels like we've been talking about that transition from fee for service to fee for value, and seeing that very, very slowly crawl along across the country, but seeing it happen at vastly different speeds, market to market, which when you think about something like primary care, makes it really hard to figure out how do we respond and how do we align incentives with our providers where we're in a fee-for-service environment that is somewhat transitioning to value, but very slowly transitioning to value, in an economic climate where every dollar matters and it's hard to invest in the things that don't have a direct return. And then want to recognize that we need to do things like, work on our clinical practice transformation model. We need to work on non-productivity incentives, but still have the realities of how do we get reimbursed in our market today, and how does that, first and foremost, how does that impact primary care? So with those three things in the background, we tend to look at primary care as what we call an evergreen strategy. It's generally right for every system, for every market, all the time, no matter how quickly or slowly our market is transitioning to value. Because we look at primary care as being, how do we drive incremental market capture? How do we have a mechanism for patient access that really starts to orient a patient to our brand, to our network, to our health system as a whole, with primary care being that front door? Creating sustainable patient relationships allows us to improve patient retention at starting with the primary care level. Primary care is our driver of regional growth for most health systems, which I would argue, primary care can't be the only strategy as we grow, but it's probably the tip of the spear when we're growing into new markets. And that's, all of those can probably live in both of those considerations, can live in a fee for service or fee for value world. But growing primary care also gives us the ability to, start building the resources that as our market shifts to fee for value, we know that's going to start with tightening utilization at that front end primary care environment. So having a network of primary care that allows us to have those patient lives in our network and focus on the leveraging their capabilities as we transition to value is incredibly important. And then overall, just primary care to us supports the systemness of a health system. It's our vehicle for patient acquisition, for retention, for referral, and really kind of becomes the core of how do we run a sustainable network of ambulatory specialties, and how does that network together, drive the strategy of our hospitals and other elements that exist within our health system. So maybe, Terry, talking about some key challenges and considerations for health system primary care strategy, we kind of broke this down into a handful of buckets, and we thought maybe among the questions we get most often is just how do we figure out how much primary care we need in our market? Because I think the experience everyone who's worked in a health system is our market needs more primary care. Every demand model you see suggests we need more primary care. But how do we know what we need and where do we need it? And while I would say there's no 100% right or wrong answer to that, we'd at least today like to talk about how we think about getting to the ideal sizing of your primary care network, and maybe some considerations around, how we might think about looking at our existing provider mix and capacity versus an ideal provider mix and capacity. So in this section, we're going to talk about how do we determine uh, what we think is the appropriate starting point. So not maybe not starting with community need, but really starting with what are our objectives for growth in primary care, with a focus on primary care office visit market share, which we think is probably the best tool for setting an objective within a market of where do we want to be. We also want to talk about leveraging community need data and then some best practices from our perspective on integrating existing practice capacity. So talking about well, what we call office visit based market share for primary care. So this is essentially, we believe for all specialties, but primary care in particular, it makes a lot of sense to kind of start with, within a given market, what percentage of the primary care market do we desire to control, recognizing the competitive dynamics and what might be realistic, given patient utilization dynamics in our market. So the table on the right is we or at least I am based in Louisville, Kentucky, and so this is just an overview of looking at the greater Louisville market. Three competitive health systems: Norton Healthcare, Baptist Health, and the U of L system. But basically, this is just an overview of how much does each organization control in terms of all primary care office visits happening in this market, and then how relevant are the independent primary care dynamics within the market. And so applying that type of logic and data to any given market allows us as a health system to evaluate, where do we stand in terms of overall primary care delivery within a market? How much of that's being deployed directly by our aligned and employed providers? How much of that care is being delivered by competitively employed providers? And how much of that's being deployed by independent primary care providers to give us a rough feel of, okay, here's how we're doing in terms of our relative number of primary care patient lives that we're managing versus competition, and how relevant to our primary care strategy are the independents in the market. And this is the type of data that we think, again, gives you that competitive look, but it allows you also to set goals, right? So if I'm the number 2 provider in the market, which in this case is Baptist Health Medical Group, and I'm looking at my desire to grow within this Louisville metro area market, I know that there are probably few patients, few existing patients. Obviously, there's going to be a lot of growth going on, new patient lives that are searching for primary care. But if I'm really looking to change the competitive dynamics and looking for true growth in the market, this is the number I probably have to start to move if I think primary care is really the driver of specialty care utilization within my system, right? So if I'm controlling 17.6% of all primary care office visits in the market, maybe that becomes the benchmark for our strategy. And we're able to then look at, okay, do we think we grow that number by utilizing our existing capacity better? Do we grow that number by saying we need to recruit incremental providers? If we're recruiting providers, are those physicians or APPs? This is the type of data that we can layer in other data elements to say, okay, this is where we are, and now what data do we need to help us figure out where we need to be? And to us, it really makes sense to start to look at that, not just, in a vacuum, but start to regionalize that data so that we can understand, not only within our home county, but within other counties, how much of the patients that are seeking primary care, how much of that volume are we controlling? And as we desire to grow into other markets, again, if our theory is that primary care is going to be that main driver of our growth, that starting point of the driver of our growth, this is the number that we have to start to change. If we have goals that are kind of driven by our market share, then the next thing to look at is, what does community need look like in terms of supply and demand of primary care? And honestly, for most health systems, the strategic driver of primary care is really how do we bring primary care resources to markets that are underutilized and that are undersupplied, and they're usually undersupplied because of 2 reasons. One, because no one's ever desired to supply primary care there, which is maybe less strategic, or they're undersupplied because it's a high growth area that's attracting new lives that will be seeking new, seeking primary care relationships. And so this is where we think it also makes sense to not look at your market maybe as a whole when you're doing community need studies for primary care, but instead to really regionalize and do what we would call targeted community needs. So break your market into sub-markets and really look for misalignment of provider resources and population that allow us to start thinking about, okay, well, our primary care market share in a given market is 7.7%, but it's drastically undersupplied in primary care, and it's a market that has demographics that are growing that we ideally would probably want to expand our market share into. So if we start to tie all those data points together, it gives us, the market share gives us the ability to say, this is where we want to grow. Community need gives us the ability to say, if we place more resources here, how likely is it that we are going to be able to acquire new patients and grow that provider or providers patient panel really quickly. And when we start thinking about that, one of the things that pops up in our minds is, if we're going to think about growing, we're going to grow through recruitment. It can't just be a physician-driven strategy, especially in primary care. We see a lot of health systems that really still focus on APP recruitment more as an operational activity. So if we have providers that are getting busy, let's get them an APP. Let's see if we can figure out how to triage some of their lower acuity stuff, as opposed to really thinking about APPs as providers who are managing patient panels and who are working in a practice environment that seeks to use everybody at top of license. What we see, Terry, is there's just a huge variation in utilization of APPs, and there's a number of considerations for that, which you'll talk about later. But I mean it's culture at the medical staff level. It's market acceptance. It's contracting model. Anything else that we would lump into that?
No, I think, it's especially the cultural element, right? Not only within the practice and the local medical community, which is important, especially with the acceptance of referrals from APPs as opposed to wanting the referrals to come only from physicians, but also the acceptance in the community and elsewhere in the practice also, because the support staff really play a key role in others accepting the APPs, as part of the team and looking at it as a team approach. But all those are huge factors.
Thank you. And then so kind of finishing out how do we get to how many providers do we need and how many do we recruit? So if we have goals, again, we have goals for how much of the market do we desire to control, measured through primary care market share measures. And we have objective assessments of relative supply and demand, and we've kind of regionalized that data. The third part that we recommend and see some organizations struggling to do is to really bring your existing practice capacity and access into the discussion of how much primary care do we need to recruit versus how much do we need to build up our existing, fill out the existing capacity within our employed provider practices. And so, we think that there of course a lot of access metrics that your organization may or may not track. Time to third next available appointment, wait times for new patient appointments, all of that. But utilizing productivity we find is a reasonable proxy for just evaluating capacity, right? And so we tend to think providers that are producing at the 75th percentile or above are probably going to have closed practices or have access or capacity issues versus those that are working below the median. This sample data on the right basically shows we have a number of providers in this primary care group that are working below the 50th percentile. And so, part of our primary care strategy might not be, if we're looking to grow our market share, might be focused more on how do we utilize our existing complement more than we're looking to incrementally grow providers. But we see a lot of different variations, right? And so these samples are all real clients. This group in particular, one is weighted way towards the physician complement in terms of provider mix, but also extremely, extremely busy. And so, when we look at, 2/3 of the group being above the median and the majority of those being above the 75th percentile, we look at this as a group that one probably could really think about how they're utilizing APPs since they have so few and the ones they have are not terribly productive, but also is likely to grow through incremental recruitment versus utilization of existing capacity. And there's also opportunities to again, as we talked about, kind of regionalizing our data. There's opportunities to not look at just primary care as a whole, but to kind of regionalize our practices and look at capacity in different markets. And this is an example from a client that had a larger primary care base spread out across a large geographic market. But in one market that they had historically been trying to grow into, had placed nearly 35 primary care providers in a market. And as we were assisting them with a medical staff development plan, we recognized that 27 of those 35 were still working below the 25th percentile. Whereas in another market, we had a market that was maybe a little bit more, historically full, but where all of our providers, or the majority of our providers, were working above the 75th percentile, and it was a market that, where we had less capacity and might have opportunities to add more providers as opposed to trying to fill existing capacity. And so layering in that practice capacity and access data to community need as we start to think about do we build, or do we build through recruitment, or do we build internally to achieve that market share number? That's how we're thinking about organizations building the right primary care complement in terms of their recruitment strategy. A second consideration is around measuring and improving patient retention, and we always feel the need to broaden the discussion when we talk about patient retention, because for a lot of organizations, patient retention means provider referral. And when we think about retention, Terry, there's 1,000 reasons why patients or providers their behavior might ultimately result in the patient leaving the network. But the broader picture is we from a primary care perspective is just how we work together to provide some level of care continuity, as opposed to just trying to manage referrals. Anything to add to that, Terry?
Yeah, because many of our patients will already have established referral relationships, right? So it's going to be difficult to get there. But one of the biggest factors when we look at all the factors on the screen tends to be timely patient access, right? Because it doesn't matter how loyal an individual is, whether it's the provider or the patient, how loyal they are to the system. If you can't get into the system, then you're already behind the 8 ball. And so, the whole referral mechanism can get quite out of kilter if the elements that are listed on the right side of the screen aren't in place and aren't optimized.
Thanks. And this is important from a primary care perspective in 2023, because I think we still see a lot of organizations purely focused on the referral and purely focused on managing what's coming out of their EMR, which gives us a ton of opportunities to miss, what happens when the referral is made, but the patient doesn't follow up and through, either because of access, because of patient choice, because geographic considerations, that patient chooses to go to a different specialist or chooses to go to a different imaging center. And so it's in today's environment, with the importance, again, of that capturing that total patient life, we think it's really important to take a holistic kind of claims focused look at patient retention that allows a health system to see, how does each of those primary care patients utilize the entirety of the care continuum, whether or not, that is, looking outside of their own EMR and basically taking a market level look. And so for the organizations that we've seen do this, there's a couple sample practices on the screen trended over time, being able to determine, for each of our primary care patients that seek general surgery, recognizing that there's variation by practice, there's variation by provider, there's there's a lot of reasons why we see variation, but from a best practice perspective, how do we start to manage that variation? Maybe not that our goal is ever we're going to want to retain 100% of our primary care patients, but when we see one practice retaining 69% of its general surgery patients, the next practice retaining 76, the next practice retaining 57, that gives us what would likely be some unwarranted variation to tackle with a goal of increasing that care continuity and focused on, again, retaining the value of that patient life. So we see both practice variation and we also see provider level variation. And I think when we take it down to the provider level, that's where it gets, really interesting and it when we look at it by provider, it starts to take maybe some of that patient choice out of there. And we start to see, when we see real massive variations by provider, patients related to a provider and their utilization of the care continuum, that really gives us something to kind of work on with our providers and something that's actionable to talk to them about. Why do we have such variation in our general surgery retention by provider? Why is your number 64%, whereas another provider is 6%? But this is the type of data that organizations we kind of feel have to have in today's environment, because there are so many opportunities with every healthcare market kind of blending together because of the mandate for growth, that we really have to have our measure of how good of a job are we doing at keeping patients within our system. And if we're blind to the part where the patients are leaving, even if a referral is made, then we're not doing our job and keeping the total value of that patient live. Dr. McWilliams, would you like to talk about utilizing resources to improve access?
Absolutely, Travis. If I can just make one comment about the previous section and the data, from the provider standpoint, what you might hear from people is, I always refer within the system. This particular set of data that are on the screen now would kind of play against that for somebody who has 90% of their patients going elsewhere. But the other thing to think about with the previous data is it's looking where patients are receiving care. And Travis emphasized in your EMR, you can see where you're referring people, but you don't know where they ultimately receive care unless you have a very well-oiled closed referral loop communication system. And keep in mind that the patients end up in some specialties, particularly orthopedics, from different points of origin. So for instance, emergency rooms, urgent care centers, inpatient activities. So it's a little bit, we want to be a little bit careful when again, getting away from the referral to this is where your patients are, seeking or receiving care. Help us drill down both on the positive side, where you have a high number going in addition to on the negative side where there's not much, retention of patients that are seen in our primary care practices. So it gives you the opportunity to drill down both on the positive side and the negative side without making the assumption that the only way that patients are getting there is from the primary care provider. So sorry about that, Travis. I just, it's the PCP in me that wants to point out that it's not always us, but we have a key influence in that, and we know where our patients, why our patients are seeking care in many instances. So utilizing our current resources to improve access, Travis mentioned earlier, the shortage of primary care physicians will continue to grow. Residency positions in primary care are growing. The most recent match showed that there are more people, more of our graduating medical students going into primary care residencies. But even under the best of circumstances, we're projected to have anywhere between 20 and 50,000 physician shortfall in primary care a decade from now. As Travis mentioned, much of that is now being looked at as, for alternatives or direct care providers in primary care, looking primarily at APRNs and PAs whose programs are putting out graduates in increasing numbers. we find that the organizations that are most successful, unsurprisingly, are those that are able to fully integrate the APPs into their care delivery models and utilize them at the top of their licensing capabilities. We mentioned before that there are many factors in that and how that happens, but really looking at the care delivery model and everyone within the practice's support of that care delivery model really makes a difference in how well we can integrate the APPs into the practice and realize the benefit of their joining us. So when we look at the slide that was up there before about the capacity of this particular group, notice that most of the physicians are at the median or above. The two at the bottom remain to be seen and bear exploration. But look at the number of APPs below the median. There can be many reasons for this. In primary care, there's the best opportunity probably across all specialties to actually capture individual APP workload as an individual, as opposed to having that roll up to the physician. But when we see this mismatch, we think, are we capturing workload correctly? If we are, then where's the disconnect in the care delivery model? It's not usually an issue of motivation or capability, but more often how they're being utilized and across the board. So in looking at that, as we mentioned before, utilization depends on culture in addition to the care delivery model. And I'm going to mention something in mid-stride when we talk about this common model that's here. And there are many models out there. But, acceptance, especially on the patient side, often depends on how individuals within the care delivery team are portrayed. So, how many of us have experienced, well, I'm sorry, Dr. So-and-so doesn't have any openings, but we could get you in with a nurse practitioner. It's almost like a secondary option. And when we talk about creating teams, it's truly a team approach. So the team takes care of their panel of patients, and you as a patient belong to that team, and your support staff need to promote the fact that we are definitely getting in with your team, and so-and-so has an appointment that'll meet your needs. Everybody then is a primary player on the team as opposed to an alternative. So one of the models that's quite common, especially in primary care, is the 1 to 2 physician APP team. The team jointly cares for their panel. I don't like that term, but we'll put it in quotes just to qualify the term of assigned patients by whatever mechanism. And by that, I mean, assignment can be complicated by insurer rules. Some insurers will not allow formally assigning patients to a non-physician, for instance, or they will be patients will arbitrarily be assigned to folks regardless of whether it's a good match or not. In the EMR, which can also be an impediment, you kind of have to pick somebody, right? And so you can pick people on the team, but the biggest cultural aspect is to portray the team as a team, as opposed to, oh, you're Dr. So-and-so's patient, but we can get you in with somebody else. That kind of undermines that whole team concept. The patient attribution process itself can be difficult because not all patients are created equal. We all know that. And so some process of patient risk stratification can help not only with figuring out the proper weighting of patients within the team and how many might be a reasonable number for that team to manage, but it can also help with template management. So appointment durations might be able to be attributed by risk stratification of the patients. Which providers the patient should see might be assisted by risk stratification. And that also helps us in managing all of those patients across the board and fully utilizing our providers rather than doing the ping pong pinball kind of thing of going from one to the other. I'm sorry, I can't help you. I'll send you to somebody else. We get a better chance of getting it right up front if we have a stratification model in place. Often in this model, APPs focus on providing preventive services, minor acute care, and seeing patients with 1 or 2 stable chronic conditions, whereas the physician on the team focuses on more complex patients, working with the care managers and care coordination efforts, and working with outside agencies. We really need to be careful in this model, especially if the physician is a family physician. And of course, if you'll recall, I have a bias there, so bear with me. If you have a family physician focusing solely on the more complex patients, you're narrowing that individual scope of practice, aren't you? It also means that you see complex patient after complex patient after complex patient, and by the end of the day, you're purely exhausted. Most of us look forward to some minor acute care and preventive services to break up that weightedness of your patient day. And so even though these are kind of guidelines, I would advocate they shouldn't be absolute, meaning the physician, even though the physician focuses on the more complex patients, we need that physician for his or her own sanity to have some preventive services, minor acute care, and less complex patients to break up the day. And I'm saying that as a family physician. Now, of course, if you have a general internist, that then narrows the scope a little bit. And I'll also throw out a bias. Many of my internist friends don't really like to do preventive services and minor acute care and those kinds of things. They like the very complex patients, so they might really fall into this model even better than the family physician would. And that's where applying the model to your circumstances really needs to be considered, and you need to consider individual interest and scopes in the process as well. Taking that model one step further and talking just briefly about clinical practice transformation, just so we do address it, even though it's more complex to address than we can in the time allotted. The basic form that's out there for clinical practice transformation is looking at team-based care delivery, utilizing everyone at the top of their licensing capabilities. So doing all the administrative tasks with the administrative folks at the front desk and the back end of the office, having our clinical support staff being utilized to do all the things they can do in patient care and not artificially limiting them, and then having the direct care providers, focused on care delivery, care coordination, leading the care delivery team, those kinds of things. If we're able to do that, that model has been proven to be able to increase productivity of the practice, enhance patient access, and do it without increasing the total number of dedicated provider hours. In fact, decreasing that, mitigating the risk of burnout, and enhancing both patient and staff satisfaction and provider satisfaction for that matter. There are a couple of downsides to that. In order for this model to be successful, the first thing that has to happen is the providers involved need to be willing to practically delegate tasks. I had a colleague, as the saying goes in the Midwest, bless his heart. But I had a colleague who had an RN for his clinical support staff person, but did not have the RN do vital signs or med lists or allergies. He did them all himself. And at one point he said, I really need more staff. And I said, Bill, what would you do with more staff? You don't utilize the staff you have now. You do all the vital signs, you do this, you do that. In fact, we could have the checkout go to a different person. He says, well, no, I really want to do the blood pressure. And I said, well, you don't have to do everything because you just can't. So Bill would have trouble with this model, quite frankly, but many of us wouldn't. The second part of it is our current benchmarking that's out there and looking at staffing ratios really looks at that one-to-one, clinical support staff member to provider kind of care delivery model. And so increasing the staff in this area, you almost go not clinical support staff member to provider, but clinical staff member to patient, or the proxy for that is exam room. And actually changing the rooming process and incorporating that clinical support staff member during the face-to-face encounter to be at first a patient advocate and then in the end a provider advocate, and involved in things like team-based documentation and those kinds of things. That takes your staffing ratios outside of normal benchmarking, but it should also enhance your productivity to where you get to the point of looking at staffing ratios by 10,000 RVUs as opposed to by provider. The other thing that this model requires is stability. You have to have stability of your provider staff, but especially stability in your support staff, because it takes a while to get these individuals trained up and to get the machine running well. So if you're going to have maximum efficiency, effectiveness, and accountability, you really do need stability of staffing, and high staff turnover really undermines the process tremendously. So, care delivery models or significant care delivery models that fully integrate the APP into the system is important, but how we incentivize our providers within the system is equally important. And very often when we talk about incentivizing, we come down to compensation models invariably. Now, we'll be the first to say that compensation models don't drive the world, and we'll also say providers aren't solely driven by money, but and the but is very often the compensation model will, at least if it doesn't drive behavior, at least influences behavior, right? So if you have a straight compensation model, a straight salary model, and there's a lot of talk these days about maybe we need to move back to that. If you look at the places that are successful in a straight salary model, there's a lot of external constraints placed on individual providers, and the system drives the process. The provider doesn't have as big a role. And not many systems have that capability at this time. So what happens in a straight salary model? Well, the individual providers achieve the minimum contractual requirements. If you're not internally driven, you don't do much above what's required, and there isn't a reason to do more. A second model is a straight productivity model, where you get basically you eat what you kill. You get a certain dollar per RVU, you generate RVUs, you get certain dollars. The downside of that model, the upside, is it can be great for the bottom line. The downside, as we see it, it tends to provoke that me and my patient mentality as opposed to ours, and a sharing mindset and team-based mindset, and can even create a practice of internal competitors, and not working together but working separately. The straight productivity model is almost like the Finding Nemo seagulls, right? It's mine, 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 mine. So everything that doesn't improve my productivity is a bad thing. Anything that improves my productivity is a good thing. So getting me to focus on anything else can be a challenge. And in the whole volume to value transition, we need people to focus on the value options to really be fully successful. So most people then focus on a base plus incentives model, and we think, well, that's great. We've got it made. We don't have the problems of straight salary or straight productivity. And I got to tell you, depending on how you design it, you can end up with essentially the same model. So for instance, a base plus incentive model that has no risk of downward adjustment or downside adjustment of the base if you don't meet certain expectations behaves like a straight salary model. Similarly, if your incentives are so weird, or your targets are so astronomical that people just have no intention of ever working toward it, you're behaving like a straight salary model. It can behave like a straight productivity model if the only incentive is individual productivity incentives. Because why is that? My only way I increase my earnings is to increase my productivity. And so everything that's increases my productivity or helps me and mine is good, and anything that doesn't is not good and bad. So what does that mean? If we create a base plus incentive models that sets the base at a reasonable level, that has a bit of a lag between our productivity and expectations and our comp, and we think the 50th percentile comp and the 60th percentile productivity is probably across the board a good place to start when you think about rate. That rate then accounts, a straight match between comp and productivity covers your straight total comp, but you have upwards of 16 to 20% of benefits above that's not covered. Plus, you want to try to do things like non-productivity incentives and others. So creating that bit of a lag between the two gets you a reliable rate that has a reliable buffer and keeps everything, setting your threshold is reasonable because it's base divided by your rate. And no matter where you're starting with your base, if you achieve the same level of productivity, then you achieve the same level of productive comp. On the downward adjustment side, we're strong advocates that gives you skin in the game. But we don't think it should be carte blanche and out of control. We think there should be adjustments and buffers within the system and some caps. So for instance, if you have a threshold that's determined by dividing the base compensation by the rate, we feel that a 10% buffer makes sense. So you don't get adjusted unless you're less than or more than 10% below the threshold, or you haven't achieved 90% of the threshold. Similarly, we think it's a little bit unfair that if you're at 80% of the threshold that you get reduced 20%. We think that there should be likely a maximum adjustment, and so a common one is about 10%, like the 10% buffer with the 10% cap, or a 15% buffer if you're in a high recruitment challenged area, or in a practice model that tends to have difficulty recruiting, like an FQHC, and then a buffer of decrease by about 10%. And then in your non-productivity incentives, look at things that align with organizational goals and objectives and are reviewed and adjusted annually, both the metrics that you're using, but also your targets. The targets need to represent challenges, but shouldn't be out of reach. And again, your options for non-productivity incentives, come from clinical quality metrics, especially those associated with paper performance elements of your payer contracts, patient satisfaction, not overall, but CG Caps has a great rate the provider 0 to 10, and you can work with that very, very well and overcome a lot of the provider angst about patient satisfaction metrics. Operational efficiencies like patient access, which we talked about is important in capacity and retention of patients, and then some citizenship things such as chart completion and those types of things all can be considered in the framework to align our objectives and move on toward the future. One of the things we talked about, though, is if everything's individual, you're still in that mind mentality. And so when do we start to reward team-based care? And that's, again, a cultural issue. We think the time is now, frankly, and it applies both to productivity and non-productivity. On the productivity side, having a mix of individual and team incentives tends to work pretty well because you have, individuals working towards something, but also the team as a whole. And especially if you're adding providers or starting in a new area, having the team looking at the practice's overall, or your pod and the practice's overall performance, can help bring that group together and that team, really working toward a common end. Some non-productivity incentives are really going to be individual, like the patient satisfaction metric we mentioned, but others can look at the team, and that's where a lot of those risk sharing paper performance elements come in, because it's all of us working together to get there. Our clinical support staff, each of our providers working to do better to achieve that level, and so rewarding at that level can be very fulfilling for everyone in the group. So that's a little bit about care delivery models, a little bit about how compensation can align incentives, and hopefully that's been helpful with our focus on primary care. Travis?
Thanks, Terry. So wrapping this up, and then we'll be happy to take questions. So again, big picture thought, primary care strategy to us is foundational to organizational success. It has been, and from our perspective, will continue to be the driver, regardless of how reimbursement shifts at the meta level as well as in individual markets. We're a big fan of leveraging data, especially claims-based market data that's available to help us evaluate our presence in the market and how well we're doing in terms of retaining patients within our system. As Dr. McWilliams spoke to, we're not just fans of primary care, but we're fans of well-incentivized and well-organized primary care. So aligning incentives between providers, the network, the health system, and building structures that allow optimal utilization of all personnel is how we're going to be successful. It's not just having primary care, but it's having an effective primary care network. And if we haven't said it enough today, we recognize the value of APPs in primary care, and across every component: who we recruit, how we structure our incentives, both at the physician and the APP level, and what model, what care delivery model we're bringing APPs into are all critical considerations for how effective that strategy is going to be. So at this point, we will wrap up and ask for any questions and be happy to answer what we can. Appreciate everybody's attendance. In terms of questions, so I had a couple directly submitted to me, although I'm not seeing any come through the chat. So if I'm missing some, let me know. For what was submitted directly to me, so there was one question about slides 12 and 13 about primary care market share and what should our organizational benchmark be. And so if you remember those slides, that's basically saying we think a great measure of primary care performance in your market and a benchmark to set for yourself is measuring our office visits as a percentage of the total office visits for primary care. So 99201s through 205s, 211s through 215s, measuring those as a percentage of all office visits for primary care delivered in the market. Now, to the question of what is a great benchmark, from our experience working with this data for the last few years, it's going to vary massively market to market, based on number of competitors, type of, going state to state, just how primary care is utilized, how primary care here in Kentucky is utilized versus South Florida is just massively different. So our answer is always, let's utilize where we are right now as the benchmark and only look to improve upon that performance and really set our primary care strategy around improving performance and not trying to get to a predetermined benchmark, or if we're above a predetermined benchmark, resting on our laurels and not seeing that as a number to improve. And then I had a second question about what percentage of your clients have PCPs on compensation models that include downward adjustments? How common is it? That seems like it might be detrimental to retention. And so I think it's a great point, right? So with primary care in particular, the competition for primary care, especially outside of urban markets, is incredible. And I think we always feel good when we can find, primary care physicians that want to practice ambulatory primary care. So in terms of how common are downward adjustments, from our perspective, reasonably common. Now, maybe a biased sample because we, from a philosophy standpoint, really do believe that physicians have to have skin in the game in terms of their performance, and models that do not have downward adjustments are functionally based salary models. I've got a handful of clients I of course won't name, but that, where they have a bunch of 20th and 25th percentile, productivity primary care performers. But it's because those physicians are very comfortable with that. They work their 28 to 32 clinical hours. They take those 1 hour patient appointment times, or slots, and without the downward adjustment to really help set the floor for what their productivity should be, they're functionally on a base salary model. And so my argument back to, isn't that potentially detrimental to retention, is in a lot of markets, can you afford to retain 20th percentile, 25th percentile positions when you're building all this expensive practice infrastructure, staffing infrastructure, business operations infrastructure around them? It's a fine line to walk, but I think coming down on the side of having that in your model, it is probably ultimately a benefit. I saw a question in the chat. Can you speak more on the difference offering appointments with an APP versus an APP on a care team? E.g., does it increase appointments with APPs? Does it reduce patient complaints about not seeing the physician? How can we best phrase the new recommended approach to patients? So I will comment on this as a healthcare layperson. So Dr. McWilliams was able to comment on that in the webinar. He is unfortunately not here with me today, where I would probably deflect that question to him. So we tend to, when we're talking about having APPs on the care team versus direct appointment with APP, yes, we do see that generally increasing appointments that are directly with APPs. The more it's not a switch that will get flicked that will reduce patient complaints about being seen by an APP, But when we start integrating that into our practice and network culture of, APPs, our caregivers, we're going to refer to them not as an alternative, a lesser alternative, but an option for access. We're going to, throughout the practice and throughout our physician culture, focus on APPs as, I don't want to say legitimate, but in a lot of physician cultures, the term legitimate provider comes up. So as we're able to reinforce our own culture about what the role of an APP is, I think we always see that reflected eventually in the patient acceptance of the APP. Another question, what is the industry norm for a primary care provider for new patient and established patient appointment times, 45 minutes and 30 minutes respectively? Yeah, I would say that would be the high end of where we're seeing those times trend. And it's ultimately going to depend on provider preference. I think if you let our operations team set your caregiver schedules for you, it'd probably be on the 20/40 and not a 30/45. Very aggressive ones are on a 15/30 or a 15/45. But I would say in general, if the closer we can get to a 20/40 would be ideal. I think 30/45 or in some cases 30/60 still exists, but those are the organizations where productivity and access are simultaneously a problem. Okay, and Tom, with that, I don't think we have any more questions, but if anybody has any additional ones, you're welcome to submit those to me offline. Otherwise, I appreciate everybody's time.
All right, thank you so much. So big thanks to Travis and Dr. McWilliams for sharing their expertise with us today, and another thank you to HSG Advisors for sponsoring today's program. Please complete the short survey that will launch in your browser once this webinar closes, and a recording of this webinar and the slides will be shared via email later this afternoon. So that concludes today's presentation. Thank you, and wishing you all a great afternoon ahead.